Hi there, everyone. We are so excited to have you back with us today for part two of this great discussion with Dr. Ziv Peled. So my name is Kayla Smock, and I am the president and founder of the Occipital Neuralgia Foundation. And part one of our discussion really focused on more so the history of headache surgery and kind of the advancements that have been made throughout the years and how headache surgery has changed. So that kind of has prompted this discussion that we're having right now, where we will be focusing more so on the future of headache surgery or nerve decompression surgery and what the future is looking like for occipital neuralgia patients. So thank you so much, Dr. Peled, for being here with us today. Dr. Peled is a Harvard-trained plastic and peripheral nerve surgeon located in San Francisco, California. And he is coming to us today with more than a decade of experience in headache surgery, so he is the right person to talk to about this. So I'm really excited for our conversation today.
Oh, thank you so much, Kayla. It's always a pleasure speaking with you and to this audience. I think there's a lot of questions out there, and always happy to answer all of them and kind of talk about, one of my favorite, if not my favorite topic, which is headache surgery and all of its components. So thanks for having me.
Mm-hmm. Yeah, no, absolutely. So most of our conversation today will be stemming from your recent publication in the JPRAS Open. So to our viewers, feel free to pull that up. It is called Introduction to VSI Migraine Surgery, and the authors were, of course, Dr. Ziv Peled, but then also Dr. Lisa Frere. So anyways, your article outlined very nicely kind of like the 5 key points in terms of advancement for headache surgery. So why don't we just dive right in? Why don't you go over kind of a few of those points and take it from there?
Yeah, well, thanks again. So I want to say, as we were talking in kind of the lead up to thinking about these two conversations, the first one we had now today, this is just my impression. I think there's a lot of exciting things coming up in the future and with regard to headache surgery. But when I thought about some of the things that are most impressive in terms of on the cusp of really being very commonplace for those of us that do a lot of this, I came up with 5 things that were the most impressive to me. I think the first is the idea that we're constantly finding new areas to treat. I think headache surgery, and I was on a webinar for the International Microsurgery Club a little over 24 hours ago, so 6 a.m. in the morning my time yesterday, honestly. Always good. But honestly, the discussion was really stimulating and fun, and it was amazing to see peripheral nerve surgeons doing all sorts of things throughout the world that are constantly innovating. And it really, what struck me, and I made this point as a panelist, was that it's kind of like manifest destiny. When you talk about American history, I think you are finding a whole field that continues to open up, and the more you find, and the more you realize where everything is and what the components of that are. So one of the things that we were saying last time, for example, was that among the developments in the first 2 decades rather of headache surgery were really just defining what the anatomy is in terms of which areas are the primary nerve targets. And so, for example, in the frontal region, we know we have the supraorbital nerve and the supratrochlear nerves, and then the supraorbital nerves. In the temporal region, we have the zygomaticotemporal nerve and auriculotemporal nerves. Then we have the 3 occipital nerves in the back of the head, as well as some rhinogenic, meaning nasal generated nerve areas. But the more we see, like I said, the more we see. And so in the kind of neck region, we now have at least one paper out looking at another nerve here called the greater auricular nerve, which is a little bit to the front of the lesser occipital nerve that we know is a factor in some patients. There's one paper that's been published by Jeff Janis that highlighted the anatomy of that nerve and its potential role in chronic headaches. And we've seen that in our practice and operated on a handful of those people over the years. Bardia Amerlak out of UT Southwestern, who's a phenomenal peripheral nerve surgeon, has written a paper about a nerve he calls the frontotemporal nerve, which is sort of halfway between that supraorbital nerve and the zygomaticotemporal nerve. I know these are kind of a mouthful, but basically there's like a third nerve that he is finding in some patients, kind of over the lateral forehead and brow, that can sometimes be involved. And another colleague of ours, fantastic surgeon and a good friend of mine, Rob Hagan, has talked a lot about neurogenic thoracic outlet syndrome. So the thoracic outlet,
Mhm.
or the brachial plexus, which is a nest of nerves that kind of comes out of your neck and goes to the upper extremity and the kind of upper back. Um, it's every medical student's worst nightmare because it's this really complicated, like Los Angeles highway set of on ramps and off ramps with nerves connecting and branching off. But while this is a problem that you find with some frequency, specifically with regards to people that have upper extremity symptoms, meaning like shoulder pain, arm pain, hand pain, sometimes upper back pain, like very lateral mid shoulder scapular discomfort, that's the shoulder blade. A significant number of those patients also have occipital neuralgia like symptoms. And so our ability to recognize the fact that you can have a completely different entity that requires surgery kind of here in the neck that might have
Mhm.
occipital neuralgia like symptoms, I think is also very important. So I think our ability to recognize these nuances is really the first thing that came to my mind when I was thinking about where are we going in the future. And I think those of us that continue to do this uh, have all recognized, the more we know, the more we realize what we don't know. And while
Mhm.
that doesn't mean things are ineffective or unsafe, I think quite the opposite. We've only gotten better, and our results really are quite impressive, and happily so. I think we continue to strive to do even better than that. Hopefully, very consistently, we will be, closer to 95% success rates as opposed to 90% success rate, which is already very, very good.
Mhm.
Another development that I think is really good, and I think that will serve everybody well, is I think better collaboration with neurologists and certainly other specialists in the area. I now routinely in my practice, and it took a long time, but have some neurologists that refer me patients, some pain management physicians that refer me patients, some ENT doctors that refer me patients, but specifically with regard to neurologists who are, I think, fairly commonly considered the gatekeepers when it comes to headache patients. If you have chronic
Of
headaches like
course.
migraines, you're not running to necessarily see a plastic or peripheral nerve surgeon right off the bat, nor should you. But I think our continued attempts at collaboration with neurologists is only going to yield better results. We have colleagues in Vanderbilt. We have colleagues at the various Harvard hospitals where I trained many years ago, who have pretty solid relationships with their neurologists and get constant referrals back and forth. And I think there's a good discussion that constantly occurs about which are the most appropriate patients to treat and which are not
Mhm.
really candidates for headache surgery. Um, but I think that if nothing else, these collaborations have led to a greater awareness of the fact that occipital neuralgia, just as an example, out of all the headache operations that we do, is something that has a surgical treatment option when more conventional and conservative therapies have failed, and surgery is never the first option. But
Mhm.
hopefully, people don't have to search for 19 years, which is the average amount of time it takes for someone to be referred to a peripheral nerve surgeon, even given a diagnosis of occipital neuralgia,
Right.
before actually seeing someone that can help them. So I think that that's really exciting. And in fact, I just got my third referral here in 2 weeks from an orthopedic spine surgeon who
Great.
now sent me a number of patients, all of whom thankfully have gotten better, but who apparently don't need spine surgery. So working with our
Great.
colleagues, especially our neurology colleagues, I think is going to be extremely important. One of the other things that I think has also been a real advent to my practice, and we had this little bit of a discussion at the end of our advanced migraine surgery course um, at the big annual plastic surgery meeting this past, I think it was October. Um, one of the questions I was asked was, what is like the one thing that you're doing now that you weren't doing 5 years ago, or or that you are not doing now that you were doing 5 years ago that has, kind of benefited your practice and your patients? And I think for me, that answer was fat grafting. Now, at
Yeah.
first, people kind of look askance and you're like, fat grafting? What are you talking about? Fat grafting, nerves, nerve surgery? What do you mean? But there's actually a growing literature that fat is a really important substance for a number of reasons. And so, again, there's one paper by Baum and Guyron, several years old now, showing that for recalcitrant or persistent headaches, despite adequate decompression, you can put fat around these nerves and they seem to recover. Now, I think at the time it was a little unclear what was going on, how is fat helping these nerves. And I think what
Mhm.
I say to my patients now and what we know from the literature, both in clinical practice for headache surgery, as well as other conditions like post-mastectomy pain syndrome, which is a nerve injury in many cases, as well as from a basic science standpoint, is the fat does two things. There is certainly a structural component to that. So if you have an irritated nerve and you have the skin right underneath it and the nerve is irritating the overlying skin, if you put some fat, and just we'll make this dramatic and put a lot of fat here in between, this nerve can still be a little irritated, but that message doesn't get sent to the skin nearly as much. And so
Mhm.
um, the analogy would be if somebody was jackhammering outside your house to reconstruct the sidewalk for 5 days, you'd probably want to pull your hair out from the noise. But if you put on a pair of noise canceling headphones, while it might not make the noise go to zero, it certainly really mutes it. And so it makes it a lot more
Okay.
tolerable. The other way that fat is thought to work is that along with the fat cells that you bring in, you also bring in some stem cells. And it is known and has been shown in the lab that these stem cells release chemicals once they take and begin to function normally at their recipient site, at their target site. They release chemicals that are neuroprotective, that are neuroregenerative, so they can prevent any further damage to the nerves, can help the nerves regenerate and heal, and are also anti-inflammatory. And so you basically have sort of like this little concoction of cells that can release chemicals that really make the nerve environment more hospitable, and is another way in which this is thought to help. And the upshot for that, at least for me over the past couple of years, where I've had occasion to do this, a few dozen times now, because thankfully we don't need this in the majority of our patients, but every once in a while people will come in and say, look, the surgery, I'm only 30% better, 40% better, and I wish I was 80 or 90% better, but I really don't want to have to cut this nerve, which is what we used to say
Mhm.
5 years ago. So if the decompression didn't work or only worked minimally, the option, if the nerve blocks were still successful in relieving your pain, was to go ahead and cut the nerve. And what you had as a result of that, depending on which nerve you're talking about, was permanent numbness. Now, and I presented this data at a fat grafting meeting last August, when I put some fat grafts into those people around those nerves, almost 80% of those patients do not ever progress to the point where they need to cut their nerves because the improvement in their residual pain is so much so that they say, look, I can deal with the rest of this little stuff, but I have all my sensation, and that's great. The other really nice thing about the fat grafting procedures is the way you harvest the fat and the way we place the fat is with really tiny cannulas. These are things that are millimeter or less in diameter. So they're really like almost small toothpick sized cannulas, although they're blunt, they're not sharp like a toothpick. And because the dissection and operative procedure is not as invasive, there's no such thing as non invasive surgery, but is relatively less invasive. Depending
Mhm.
on the patients, with things like Pronox, which is inhaled nitrous oxide that you can use safely in the office. This is something that you can do actually in the office very safely.
Okay.
And with Pronox and a little bit of local, patients are able to drive home a few minutes afterwards. It's not even like anesthesia, it's analgesia, really.
Wow.
And so, total incision length sometimes, if you're doing isolated nerves, is less than a centimeter. So it's a very well tolerated procedure that really has a nice bang for your buck, so to speak, in terms of what you have to go through and in comparison to uh, what you get out of it. And there are that field in and of itself continues to blow up because we're doing this, like I said, for post-mastectomy pain syndrome, for nerve relief in other parts of the body. So the whole idea of using fat for all sorts of things, not just structural defects, is really an interesting field. Um, Moving
And
on. Yeah, go ahead, please.
no, okay. So with the fat grafting, is that liposuction like on your own body, like at your waist, for example? How does that
Yes.
work?
Yeah, that's a great question. And the answer is yes. We do liposuction a little bit of fat from another part of the body. Usually, the volume of fat that we take is so small that it doesn't confer an aesthetic benefit, although certainly you could request that
Okay.
we take a little bit more here and there to slim down a little bit, but that's not obviously not the goal here. And the other thing
Mm-hmm.
that's kind of implicit in your question, which I think is really astute, is one of the things that people have postulated is, do we know if there's a difference between fat cells harvested from the waist, from the inner thigh,
Right.
from the abdomen, or from the back, and how they differ? And there is, and this stuff hasn't been published yet, so I won't say the author's name or what the exact findings are, but there are certainly differences that you can discern in terms of the protein makeup of the fat cells harvested from different areas of the body. And it's probably going to be the fact that we will be able to demonstrate that there are different levels of those various cytokines or chemicals that these fat cells release when harvested from, let's say, the back versus the thigh versus the abdomen. And so
Mm-hmm.
at some point, I wouldn't be surprised if, within 5 years, we say, look, if we have a mastectomy defect and a concavity in your chest wall, or not mastectomy, lumpectomy defect, partial mastectomy defect, and we want to just structurally fill that so that we have a
Mm-hmm.
more even surface to the breast mound, we harvest fat from the abdomen. But if we are looking to pad nerves and to provide this specific kind of anti-inflammatory cytokine environment, we're going to harvest
Mm-hmm.
cells from the thigh. And we'll be
Okay.
able to tailor our desired outcomes to the fat harvesting procedure. So, yeah.
Mm-hmm. Yeah, I mean, this sounds like an incredible advancement and a great step forward in the right direction because for so long when you had like you weren't happy with your results from decompression surgery, the
Mm-hmm.
next step kind of was excision surgery where you were left with that numbness, and that was a question whether or not you wanted to deal with, do you want to
Mm-hmm.
deal with permanent numbness or do you want to deal with this awful head pain like moving forward. So this is this is really exciting.
Yeah. It's super exciting, and I think again the procedures themselves, with all of the other advancements in terms of just analgesia relief, really
Mm-hmm.
things that can be done in your office. Obviously, you have to have the right setup, but very carefully, very
Mm-hmm.
safely, and because you're not really using anything besides local anesthesia from an anesthesia standpoint,
Yeah.
literally people can do this on their lunch hour and actually drive home. So yeah,
Great.
it's pretty nice. Um, so
Great.
moving on to our five top things, we have those top three: the new anatomy that we're discovering, so the new landscape, the collaboration with neurologists, the fat grafting. I think one of the other things that's interesting is that we are recognizing that decompression surgery is applicable to lots of other different kinds of headache subtypes. So we talk
Mm-hmm.
a lot about migraines and whether this can be used to treat migraines. And of course, I don't truly believe that we're treating migraines, which I think I said this in our first talk, is a chemical
Right.
abnormality. We are treating a mechanical abnormality, so it's neuralgia, but there's a lot of overlap in the symptomatology. And both patient populations have severe headaches and head pain. But we
Mm-hmm.
now know, and it has been shown, that this type of surgery is good for other kinds of headaches. So, for example, Jeff Janis once again published a paper within the last couple of years showing that decompression surgery is effective for estrogen associated headaches. So, for people
Mm-hmm.
that have headaches that occur with a certain point in the menstrual cycle or during menopause or the onset of menarche for women, these headache operations are very successful. We have seen a few papers talk about the ability to treat what are called nummular headaches. These are much rarer subtypes of headaches, but nummular just means coin shaped. So we've certainly seen over the years that there are people in the office that come in and can go, it's exactly right here. There's like this area, it's about the size of a silver dollar, but I can point to exactly where it hurts. And when you numb those areas and you can, operate on those areas, there's a pretty good success rate in relieving those headaches, which is, again, very profound and oftentimes requires small incisions that people have described being able to do under local in their offices as well. I think the pathology there is really interesting and it remains to be completely worked out. But I
Mm-hmm.
think there's two schools of thought. One is that there's a blood vessel compressing a super, super tiny nerve that's hard to see even with your high powered loops during the surgical procedure. But people have described finding an abnormally large little blood vessel just under the scalp that it's likely compressing that nerve. And I just wrote a paper with a phenomenal surgeon in Italy, Eduardo Raposio. And he has shown and presented data that it's actually not necessarily the fact that these abnormal blood vessels are pressing against other nerve fibers, but a lot of these blood vessels have nerves within their walls. And when you're cold, the nerves cause the muscle in the arterial wall to vasoconstrict. When things are warm,
Mm.
they dilate. So there are nerves within the blood vessels. And he had a very nice presentation last year in October at the annual big meeting, plastic surgeons. There's a whole peripheral and migraine surgery section now, which is just shows you uh, how
Yeah.
how much research there is, how many people are actually taking an interest in this type of work. But
Mm-hmm.
he showed that under electron microscopy, which is a really high powered microscope, you can see abnormalities in the blood vessel wall. And it is thought that perhaps these abnormal structures that are within the vessel wall are pressing on the nerves within the vessel wall, causing it to abnormally dilate or constrict and therefore causing pain as a result of what's happening to that blood vessel. There are also uh, several papers now within the neurology literature showing that there are nerves from the dura, which is the covering of the brain, that pass through what are called cranial sutures. So many of us may know if you're a little baby, let's say a 1 year old, you have that kind of soft spot in a couple places on your skull. And that's because the brain hasn't grown to its full size. And so, like plate tectonics, you have little plates and little parts of your skull that haven't completely fused yet. Um, when those bones fuse, that fusion line is called a suture, and it has been shown in both rodent models and now in humans that there are little nerves from the dura, the covering of the brain, that can pass through those cranial sutures and go to certain
Mm.
areas, and that it's thought that that may be a cause of pain. And so I've seen a couple of patients over the
Okay.
years with these nummular headaches. There shouldn't really be a noticeable nerve right here, but when you make that
Mm-hmm.
incision, you open it up, sure enough, there's this little thing coming out of the skull, and get rid of it, and patients do well post-op. Um, and then I think from a final standpoint, in terms of things that I mentioned in my paper, but we can certainly talk about others, I
Sure.
think our ability to uh, image and diagnostically try to determine who's a good candidate for surgery continues to improve. Lisa Frere published a really nice, very elegant in its simplicity paper about pain sketches, which is where she had patients kind of demonstrate the kind of radiation and origination points of their pain. So, it starts here and it kind of goes this way, and was able to
Mm-hmm.
show that when people had very typical kind of pain sketch patterns, their ability or our ability to predict who would have a successful outcome was very good. They had very high success rates. When people had pain sketches that didn't follow typical anatomic patterns, results weren't as successful. So if you had a pain that started here, but that went, down to your nose and then down to, your Adam's apple. There's no nerve that goes in that direction.
Mm-hmm.
And so that might be a person that has a different kind of pathology, and you may want to, think twice about running to the operating room with that kind of person. Um,
Mm-hmm.
and then certainly we have imaging technologies that continue to improve. So your typical MRI for many years was what's called a 1.5 Tesla magnet. The Tesla was the strength of the magnet in the MRI, and therefore the resolution of the images that you got. Now, 3 Tesla magnets are pretty common. You can often find those in most imaging centers, but you have 4.5 Tesla, 9 Tesla in some research institutions, and apparently there is one research institution that has a 15 Tesla magnet. And I can only
Well,
imagine the resolution of the images that we're likely to see
mm-hmm.
with those patients. It's certainly not ready for prime time yet, and it remains to be
Mm-hmm.
seen how safe a magnet that is that strong is. I can't imagine it won't be safe, but
Yeah.
we have to do our due diligence in terms of assessing that before you find one of these machines in every imaging center around the block. But I think certainly our ability to find and see and image differences within small and smaller and smaller and smaller nerves over time will continue to improve. So I think
Mm-hmm.
we have a really bright future ahead of us, and we'll be able to sometimes, maybe sometime in the near future, be able to diagnose people who actually have pathology by seeing it, not just with nerve blocks and by symptomatology. So yeah, it's really a
Right.
lot of things to look forward to, and I have other things we could talk about as well, but I don't want to monopolize the mic since you're.
Yeah. No, no, absolutely. I mean, I know I've learned a lot during this conversation, but I mean, I think diagnosis is such an important factor for
Mhm.
occipital neuralgia patients. And I mean, we ran a study, like an informal survey back in 2021, and through that we found that the average time since the onset of symptoms until an accurate diagnosis of occipital neuralgia was 4 years, which is just it's way too long. And then you had just mentioned 19 years up until an actual consult with surgery. So
Yeah.
there's such a need for diagnosis. And I think also there's so much overlap, like you also had mentioned, in migraine symptoms versus occipital neuralgia symptoms, and then the many other types of headaches, but they're all like some of them need to be treated differently. So, I mean, I think diagnosis would be such an incredible factor to kind of sort out. So like with like the stronger magnet, like you mentioned, we're thinking that that will show nerve damage, right?
Yeah, we're thinking it'll show nerve damage, and will not only show nerve damage, but will show nerve damage in very, very tiny nerves. So the way I think
Okay.
about it is for things like that, and we don't know exactly how great or not great those images are yet. Again, these are things that have been
Mm-hmm.
demonstrated in a few studies and a few papers that have been presented at meetings. But there's no question, like when you look at images of the knee with a 3 Tesla MRI for someone who
Mm-hmm.
has an ACL injury, you can see so much more than you could 10 years ago when all the magnets were 1.5 Tesla. So I can only imagine what you'd be able to see if you're using a 15 Tesla magnet.
Mm-hmm.
And again, I think you'll be able to really, I think perhaps with time, one of the things someone mentioned on the International Microsurgery Club panel that I was on this week, and I don't know who quite we attribute this saying to, but knowledge in surgery comes not so much from knowing who to operate on, but knowing who not to operate on. And I think that
Mm-hmm.
that's, I think those are wise words for people that have been in practice for any period of time, because certainly surgery helps a lot of people, but it doesn't help everyone. And, you always feel a little bad when someone, even if you do a good operation, and they don't get any better. And I think any
Mm-hmm.
good surgeon should be looking at him or herself and saying, look, if I had an outcome that, maybe person didn't get worse, but they didn't get any better, and I really thought they would, why was that? What was going on in their uh,
Mm-hmm.
background that made this operation not successful? And again, perhaps if we had the ability to image these people, we would see things
Right.
that maybe don't preclude surgery even, but maybe allow you to, um, address these patients in other ways. So, for example, we might find that if you have a certain kind of abnormality that doesn't look as
Mm-hmm.
severe on the 15 Tesla MRI image, maybe those are people that we can use fat grafting for as a first procedure. And because the damage
Mm-hmm.
isn't as bad on the nerves, those nerves will heal up without any big open operation. So these are
Right.
just the kinds of things that I think about and that I hope we're able to offer people as time goes on.
Mm-hmm. So going back to the fat grafting. So
Hmm.
to be a candidate for fat grafting,
Hmm.
let's say it's after a decompression surgery, do you
Hmm.
typically do nerve blocks again?
Yeah, for a couple of reasons.
Okay.
One, you want to sort of vet your diagnosis, for lack of a better way of saying it. I'm a
Mm-hmm.
big fan of saying my diagnosing you with, for example, greater occipital neuralgia is based upon your history, your physical examination, and even if the
Mm-hmm.
symptoms are classically electric shooting pains exactly in this distribution, you always want to make sure that it's not just the greater occipital nerve that's involved, for example. So if you block the greater occipital nerve and all the pain goes away, great. That's probably your only target. If you block it, half of it goes away, you have to think about,
Mm-hmm.
well, what else is causing that pain? And another paper that I just published in December really speaks to the nerve, quote, anomalies, which are the unusual branching patterns. It turns out they're not unusual. Okay. So uh, people often think of anatomy as normal and abnormal, like your heart's always on the left side of your chest, but there is a condition
Right.
known as dextrocardia where the heart is on the right side of the chest. Now, that has a lot of other problems. It's there since birth. It's very rare, but it does
Mm-hmm.
happen when it comes to peripheral nerve anatomy. My saying is there's no such thing as normal and abnormal. There's only the most common variations because these differences in anatomy are very common. And so if you look at all the books and
Mm-hmm.
all the pictures and all the books, um, the greater occipital nerve doesn't touch the lesser occipital nerve, but I can show you images where they connect. And so if you
Mm-hmm.
have pain that's going up here, it may be just coming from the greater occipital nerve, but there may be a branch from the lesser occipital nerve that is also going there. And so
Okay.
to answer your question, if you block someone and you're going to do a fat grafting procedure, but their pain only goes half
Mm-hmm.
away, there is perhaps another nerve that's causing that, and you should probably put some fat around that other nerve also. So yeah, the
Okay.
workup is very similar because you're having a surgical procedure, even if it's a relatively less
Mm-hmm.
invasive one. You want to make
Mm-hmm.
sure you're obviously addressing everything you can and can safely do in one procedure.
Right. And then I think a lot of our members and our patients get confused that these surgeries are typically done by a plastic or a peripheral nerve surgeon versus a neurosurgeon. Can
Hmm.
you explain that a little bit more too?
Yeah, great question. One we get a lot. So I
Hmm.
certainly don't want to speak for neurosurgeons in general, but
Hmm.
basically, most neurosurgeons tend to focus on the brain and the spine. And there's certainly
Sure.
plenty of work to be done in those areas alone. And that's, to my understanding, and I know lots of neurosurgeons are all great people, that is the bulk of what you learn about in neurosurgery training. You don't get a lot of operations that you do on the wrist for the carpal tunnel patients, or on the elbow for the cubital tunnel patients, or in the leg for the tarsal tunnel patients, neuralgia paresthetica patients. There's all these nerve compression conditions. So neurosurgery does not typically focus on peripheral nerve anatomy, but rather central nerve anatomy, i.e., the brain
Okay.
and spinal cord. The other thing that has put plastic surgeons at the forefront here is the fact that we operate all over the body and always have. So there are a lot of plastic
Hmm.
surgeons that focus on hand surgery. And hand surgery, along with the orthopedic surgery colleagues that do that, um, when people injure their hands by cutting their fingers and therefore injuring a tendon or a bone or a ligament, oftentimes they injure nerves. And so we have lots of experience in working in those areas and fixing nerves in the fingers for decades now. And we have applied
Mhm.
those same techniques to fixing nerves elsewhere. So that's another way in which kind of plastic surgery has been at the forefront of this. And then I can't recall exactly if we went over this during our first conversation, but how this all started in the recent past, which is to say around 2000, was Bauman Gairon, who was a plastic surgeon, a very prolific cosmetic aesthetic surgeon, was doing a lot of brow
Mhm.
lifts, and he during a
Yeah.
procedure was removing certain nerves and removing muscles around other nerves. And he found that a significant number of his patients who had bad headaches before surgery were coming back to him and say, look, I love my aesthetic result. I look younger. This is terrific. But I should tell you, I used to have these horrible headaches, and either they're significantly better or gone. And then instead of saying, oh, well,
Mhm.
that's kind of neat, great, he really took that observation to heart and started to formally
Mhm.
study it. And, a few years later, we realized that as plastic surgeons, we were on the forefront of that field and have continued to push that forward. Because I think a lot of people,
Mhm.
uh, as a pitch for plastic surgery in general, the non-aesthetic part, everybody thinks of plastic surgeons as the doctor 90210s, and there's plenty of
Yeah.
those around, and they're great people. They do wonderful surgery, obviously in appropriately selected patients. Aesthetic surgery is wonderful. It can be very uplifting, and
Mhm.
there's a lot of wonderful benefits. I do some aesthetic surgery myself. Uh, but plastic surgeons really do a lot of other things. All the breast reconstruction that you see, those are plastic surgeons. A lot of times when you have chronic wounds somewhere, how are you fixing that? Who's taking tissue from your stomach or your back and putting it on the leg to cover an exposed bone or artery? It's a plastic surgeon that's doing that work. Cleft lip and palate surgery, plastic surgeons, face transplants, plastic surgeons. In
Mhm.
fact, the first kidney transplant ever performed was by Joseph Murray, who was a plastic surgeon at the Brigham and Women's Hospital, and he won the Nobel
Wow.
Prize for that in the early 1990s. We used to pass by that Nobel medal every day on rounds, and it was really just an impressive thing to see. So I think the idea
Wow.
that plastic surgeons can do things beyond making noses straighter or, plumping up your
Mhm.
cheeks, I think is a
Mhm.
little bit of a shift that has to occur in people's minds. And I think some of us, do a lot of nerve surgery and are pretty good at it.
Yeah,
Yeah.
definitely. So, moving back to the advancements in headache surgery and decompression surgery, are there any other things that are on your mind that we should discuss before we close this out?
Yeah. I mean,
I
how
mean,
much
we
time?
hit a lot.
Yeah. So yeah, there's I think that, one of the other things I keep thinking about is we use a lot of nerve grafts off the
Hmm.
shelf now, and people have been talking about the fact that these nerve grafts have been a big development in our ability to bridge big nerve gaps. So if you have to cut a nerve, for example, for breast surgery, and you have to reconstruct that nerve because a lot of that nerve was removed because you have to remove the breast for either cancer prevention or
Right.
cancer treatment, we now have these
Hmm.
really great grafts that we can pull off the shelf that are excellent matrices for the neurons to grow through to reconstruct and reach their downstream
Hmm.
targets. Um, but we continue, and this is complete speculation now, but people have talked about for years, is there a way that you can manipulate those grafts to make them even better? So can you seed them
Hmm.
with Schwann cells, which are the cells that kind of support nerves in your body that coat the nerves with myelin? So it's kind of like nerve insulation and make the nerve impulses travel
Hmm.
um, more quickly and efficiently through those nerves. Um, if you could put certain chemicals within those nerve grafts that would
Hmm.
allow the neurons to grow through them much more quickly,
Hmm.
more robustly, I think that would be an amazing advent. We have all sorts of things that can support nerves and nerves that have been operated on. So, for example, if
Hmm.
you do a nerve surgery on something, there's always a chance that scar tissue can form. We now have
Hmm.
things like grafts that can help minimize that especially if you have to go back in and re-release a nerve. Um, so I think, there's lots of things uh, working around the nerve procedures that are the basis of all of this that just
Hmm.
continue to make it better. So I think, for example, in the years when the iPhone was first invented, it seemed like every new iPhone was a revolutionarily amazing step forward. Now we could send
Hmm.
faxes, now we could talk to the phone, now we could charge it wirelessly. But
Hmm.
at some point, you've made so many advancements that each advancement is now evolutionary as opposed to revolutionary, so to speak. So it's a
Sure.
better, faster processor, it's a better camera, but it's still a camera, and yet the pictures are nicer and the videos are cooler, and you can have more
Hmm.
effects. And so I think we are kind of getting to that very early maturation phase with regard to headache surgery. It's been around almost a quarter of a century now since Bauman wrote his first paper back in 2000. And
Right.
we've seen so many advancements that, now a lot of these things are working, I don't want to say around the edges, they're still important advancements, but they continue to make
Hmm.
everything that we've already done even better. And I think the results will continue to speak for themselves. So it's a really
Hmm.
exciting time to be a peripheral nerve surgeon and for sure a headache surgeon.
Yeah. No, absolutely. And I mean, I feel like I can speak on behalf of so many occipital neuralgia patients. This conversation alone has offered so much hope for like the future and even some clarity over what so many of us are dealing with and battling with our pain. So thank you for that.
Well, I'm glad that's helpful. And we had talked about, and I invite people to send in their questions or queries, comments.
Hmm.
I'm sure this will be posted on Instagram and maybe Facebook, or
Yeah.
wherever your social media accounts take you. So we really, especially myself, I love to have people ask questions. We can't give people
Hmm.
specific diagnoses. So if you
Hmm.
call or comment and say, hey, I have this and that's what do you think is going on, I can't tell you, oh, you've got greater occipital neuralgia. That's not fair based upon a
Hmm.
quick social media chat. But we can provide general
Hmm.
information and certainly provide you with perhaps resources where to go to learn more.
Hmm.
And hopefully there's more peripheral nerve surgeons being minted. It's happening slowly,
Hmm.
but it's happening. And so hopefully there'll be
Hmm.
people closer to home, because I still think it's kind of crazy that people have to fly from Australia or Finland to see me.
It's,
That
yeah.
really shouldn't be the case. So
Hmm.
yeah, hopefully with time we'll be able to teach people more and give them more resources to go more locally as well.
Sure. So, remind us again before we close this out where we can find you and learn more about your practice.
Oh, thanks. So we have a website. It's pelledsurgery.com. We have an Instagram feed that's Peled Surgery, and the same thing with our Facebook page. There's also a Reddit account, Peled Surgery. So you can feel free to comment, ask questions. There's a lot of information on our website, mostly under the blog posts. These are things that we've posted in the past, but they're also collated on our website, where you
Hmm.
can kind of learn the answers to a lot of the questions, a lot of things that we've covered over the last two conversations. But if people are interested, we may be able to kind of answer them in video
Hmm.
format so that we can kind of condense. People don't have to read long pages of script to try and figure out an answer to the
Yeah.
question.
Yeah. No, absolutely. And then if you're interested in learning more about the Occipital Neuralgia Foundation, our website is onfsupport.org. Our Facebook is just Occipital Neuralgia Foundation, and then our Instagram is occipital.neuralgia. And then for those of you who may have missed part one, absolutely go check that out. Again, we went over more so like the history, the optimization of headache surgery, which really prompted such a great conversation today. So thank you so much for being here, Dr. Peled. This was great.
Yeah, I really appreciate it. And, again, I've said this before, even when we spoke a couple of years ago, I think it's an amazing uh, group and thing that you've created with the ONF. And I wish you all the
Thank
success.
you.
You're gonna really crush it and help a lot of
I
people.
appreciate that. Thank
Yeah.
you so much. I appreciate
Thank
it.
you for having me.
All right. Thank you
Bye
so
bye.
much.
Anytime.